يعني بسم الله الرحمن الرحيم. طبعا اولا وكل سنه وحضراتكم طيبين. احنا النهارده بنزاول نشاطنا العلمي الاستاذ دكتور عبد السلام رئيس قسمنا ارساه، والنهارده عندنا توك مهم جدا دكتور عبد السلام عطيه هيتفضل بيها. and would like to thank you Professor عبد السلام for giving us the time and the effort and would like you to start. انا بعتذر مره ثانيه للتاخير، فمش عايز اتاخر اكتر من كده. اتفضل يا دكتور عبد السلام.
شكرا يا فندم، شكرا بحضرتك. ألف شكر لحضرتك، والحقيقة أن يعني مشاركة القسم كله دي حاجة مهمة جدا بالنسبة لنا. التوك النهاردة الحقيقة يعني I would like to thank Pfizer for sponsoring the talk, which is really amazing type of presentation. It is mostly scientific rather than commercial. And I would like to thank my colleague ابنتي العزيزة الدكتورة يمنى محمود، لأنها she will present something related how we make a decision in the era of very rich kind of treatment. And I will go immediately to the talk, which is will basically discuss the real-world experience with CD46 inhibitor, which are a new era in the management and breakthrough in the achievement of not only good response and overall response, overall survival, but also very good quality of life. So let us start with Cdk46 inhibitors. There are the CCLab. So I wish you are following me. These are the group of the Cdk46 inhibitors. The three drugs that are available in the market right now are the amiCCLab, palbociclib, and ribociclib, which are really, we all have experience with each of them. They are not much different in their chemical structures and their composition and clinical characteristics. Oral medication, we are in the era of oral medication, which make the life of the patient easy, and the assessment very good for the patient and acceptance. They have different doses which range from 125 daily, 25 milligram daily for the palbociclib, ribociclib 600 milligram daily, and the amiCCLab about 200 milligram BID. They are given in schedules of 3 weeks off, 1 week, 3 weeks on, 1 week off in the palbo, 3 weeks on, 1 week off in the ribo, and continuous for the amiCCLab. They have different half-life, which is almost 27 hours, 32 hours for the ribo, and 17 to 38 hours. What is interesting is their overall response as a monotherapy, which is 6, 2.3, and 19.7. But actually, this doesn't matter a lot because we never use any of them as a monotherapy. They have a very similar pattern of toxicity, which is basically neutropenia that could happen in about 50% of the patient with palbo, about 28% in the patient with the ribo, and 27% of the amiCCLab. In addition to the diarrhea, which is characteristic for the amiCCLab, and the thrombocytopenia, which is more with the palbociclib. The CNS penetration is only observed in patients who are receiving amiCCLab. So let us review the clinical trials that has been used for the approval of these Cdk46 inhibitors. We have the Paloma 2, the Mona Lisa 2, and the Monarch for the amoeba, for the bulbocicilab, ribocicilab, and amebicicilab. If you look here, you will notice that the hazard ratio almost similar, about 0.58 in the Paloma 2, 0.56 in the Mona Lisa 2, and 0.54 in the Monarch 3. You look at the curve, it looks very similar among the three trials, with almost identical BFS in patients in the control arm of the three trials, about 14.5 months and 14.7 months. The curve looks very identical among the three groups, and this is tell you that there is no much difference in the efficacy of the trials. This is the second line approval of this medication according to the Paloma 3, we're using the bulbo, the Mona Lisa 3 using the ribo, and the Monarch 2 using the amebicicilab. It was all were phase 3 trials, all has randomization of 2-to-1 using the control, and the control was basically placebo and fulvestrant. The primary endpoint was the progression-free survival, and the secondary endpoint was the overall survival. This is very important results of the Paloma 3 using bulbocicilab and fulvestrant, and compared with bulbocicilab and placebo. And you will notice BFS around 11.2 months compared with the control of 4.6 months. What is important, and I would like to share with you, if you look at this part of the curve, you will notice almost very delayed separation of the curve between the curve, and this is because you don't expect rapid response in patients who are in the endocrine therapy. And what is impressive in this trial is the hazard ratio 0.49, and the significance, the p-value is highly significant, and the absolute improvement in the progression-free survival arm was 6.6 months. This is quite impressive, and the curve are nicely separated between the placebo and the bulbocicilab arm. Look at the overall survival in the intention to treat patients. There was a significant difference of about 6.9 months between the control arm, 28 months compared with 34.9 months, and the inpatient who are receiving the bulbocicilab and fulvestrant. Yes, this is a cross comparison between the three trials using the chemotherapy, this Cdk46 inhibitor as a second line therapy in patients with metastatic endocrine receptor positive HER2 negative breast cancer. In the Paloma 3, the Mona Lisa 3, and the Monarch 2. All have, as I mentioned, are randomized clinical trial with a control, with a study to control 2-to-1 randomization, and the same with a similar number of participants. The progression-free survival was almost steady different, which is 6.5 months, 7 months, and 7 months across the three trials. And the hazard ratio, as I said, is almost the same, 0.49 and 0.59 and 0.53. Overall survival here, difference of 7 months compared with 8 months and the 9 months. What is interesting in that the Paloma 3, the investigator will very encourage to participate patients who have received barrier chemotherapy, first, second, or even third line of endocrine therapy, while the Mona Lisa 3 only one line of endocrine therapy were given, and there were heterogeneous groups. No period chemotherapy were allowed, and the same was applied for the patient on the Monarch 3. And this gives you more trust in patients who were participating in the Paloma 3, and that's a patient who could be candidate for this medication are really have been exposed to many line of treatment. So paving the way in the clinic. Actually, what is interesting in this trial, in this presentation, is that we are not going to discuss actually the trials, the clinical trials. We are going to discuss a real-world data, real-world experience, what is called post-marketing experience. This is the start point that we are comparing the clinical trials, the Mona Lisa 3, the Monarch 3, and the Paloma 3. As you said, the Mona Lisa 3, as you can say, is the Mona Lisa 3 is 12.8 months. Difference in the progression-free survival. The Monarch 3, 9.3 months. And the Paloma 3 is 4.6 months. But remember, this is not a fair comparison. As I had mentioned, that there have too much pre-treatment of the patient who have been participating in the Paloma 3. And as far as the level of pre-treatment increase and progression-free survival in the control arm decrease, you are still seeing a difference among patients who were participating in the Paloma 3. The randomized clinical trials data support the regulatory approval of these new drugs. In the Paloma 2, using the letrozole as agent, the active agent, in addition to the palbociclib, with a difference with a progression-free survival of 27.6 months compared to 14.4 months. A really impressive difference, and high hazard ratio, highly impressive higher hazard ratio, 0.56, with a highly significant p-value. And the Paloma 3 is still the same, with a progression-free survival of 11.2 months compared with 4.6 months, and the same similar hazard ratio and very significant p-value. Yes, we have to understand what we mean the difference between a clinical trials and a real world data, and which more you can trust. Actually, the randomized clinical trial measure efficacy and safety of an intervention in a specific patient population. It is designed to show causality. It is utilized a specific protocol with uniformly assessed endpoint and a randomized patient to treatment or the comparator. So it is conducted in a highly monitored, controlled environment, while the real-world observational studies measures actual effectiveness and safety of an intervention under real-world condition that has already been approved by the authority, by the health authority, FDA, for example, not causality or hypothesis generation. It assesses the patient-reported outcome, such as quality of life and satisfaction with their therapy in real-world setting. Also, sometimes we not only assess the patient satisfaction, but also assess the physician comfort with this line of treatment, their assurance about the quality of this treatment. It is provide insight on the practice pattern of practice in the practice pattern across diverse clinical settings. So it is important in this kind of studies that we reported the community service centers that are treating a cancer patient. We don't randomize patient, and the bias may be introduced by prescribing pattern and lack of informed assessment outcome. This is more trustable and more real and more beneficial for the physician to make decision. Also, notice that most of the time in randomized clinical trial, we choose patients that have a performance status which is 0 to 1. Most of clinical trial use patients with 0 to 1 performance status, and they usually put a cut limit about the age. But in the real world, we don't use this performance status limitation or the age limitation. So furthermore, we may have data that help us expanding the approval. For example, FDA approval of palbociclib and endocrine therapy in men with HER2 positive, hormone receptor positive HER2 negative metastatic breast cancer. Actually, it is most impossible to have a clinical trial on metastatic breast cancer in male who are hormone receptor positive HER2 negative breast cancer. But if you review the clinical, the electronic files of this patient who have been treated based on the previous approval, in the female studies, you can guarantee approval based on data from electronic health record of post-marketing report of real-world use of EPRANS in male patient sourced from 3 databases, EVACA insurance database and Fintron health breast cancer database and the Pfizer global safety database. This is real-world data can inform us about changes in treatment pattern in hormone receptor positive, HER2 negative. Actually, in the era prior to Cdk46 inhibitors era, we have about 60% of the patient treated with endocrine therapy compared with 40% treated with chemotherapy. But after this, we have completely different. Only 13% of the patient received chemotherapy and 5% receive others, mostly immuno, for example, while more than 82% of the patient received either endocrine therapy alone or endocrine therapy plus Cdk46 inhibitors. And this is very important change that we are decreasing the pattern, the share of the chemotherapy in the management of metastatic breast cancer who are hormone receptor positive. And this means what? This means good quality of life and good more patient satisfaction. We have many studies about real-world studies with palbociclib. We have 4 studies that has been assessed the real-world experience with palbociclib in HER2 positive, in HER2 negative, hormone receptor positive, advanced or metastatic breast cancer. It includes about 250,000 patients worldwide since the first approval of palbociclib in 2015, in February 2015. We have the IRIS study, the Fintron study, and the Polaris study, and the expanded access program. This IRIS study were in 3 countries, United States, Argentina, and Germany. It is multi-center. It has about more than 1,000 patients across these 3 countries. It is a medical record chart. Fintron study retrospective analysis, more than 2.2 million cancer patient database were reviewed in more than 280 United States cancer clinics. It is a comparative study. Polaris study, it is a prospective, it is a non-intervention. It included about 1,500 patients in United States and Canada. And finally, we have the expanded access program. We will start discussing these trials, which, as I mentioned, are very important for us to get the trust and the experience from the real world practice among different centers and different countries. As I mentioned, it was in 3 countries, United States and Argentina and Germany, almost in the same time till October 2017, and it includes many physicians' experience. So we have experience from North America, South America, and Europe. We have physician eligibility and patient eligibility. The physician eligibility should be oncologist and treating patient with HER2 positive, hormone receptor positive and HER2 negative advanced breast cancer. And the patient eligibility, they must be more than 18 years old, confirmed the hormone receptor positive HER2 negative, received palbociclib combination therapy period labeled condition. Look at the data. This is, they have a median age or around range from 60 to 65, and they are from the 3 countries participant, mostly from the United States, the majority from the United States. They will have both either visceral or non-visceral disease. And this is very important to include patient with visceral disease in endocrine therapy. And as you can see, a good percentage of the patient who have visceral disease, more than 40% of the patient have visceral disease, either in Germany or in the United States. Look at the performance status. Yes, a good percentage have performance status 0, but majority are in performance status 1, even stage performance status 3 are included, and more than 3 are included. This is the proportion of the patient who have those difference, almost whether they receive the palbociclib at the standard dose, which is 25 milligram daily, or reduced dose 100 milligram daily or 75 milligram daily. And you can see that the majority of the patient received the full dose, either in the with palbociclib plus aromatase inhibitor or the palbociclib plus fulvestrant. The same in the Argentina and the same in the Germany. It looks that the Germany to relate the the palbociclib very well. Yes, the percentage of patients who need dose adjustment, only a small percentage of patients need dose adjustment, either 20% or less need dose adjustment, and less than 10% of the patient need dose adjustment in Germany. ماكينات الألمانية بقى. What is interesting about who the number of the patient who continue survival, progression-free survival after starting the palbociclib with aromatase inhibitor, more than around two-thirds of the patient have progression-free survival at 2 months. At 2 years after they, while they are in the palbociclib and aromatase inhibitor. Higher percentage of the patient have around 80% of the patient have progression-free survival at 12 months when they receive palbociclib and fulvestrant. Similar studies, similar data were noticed in patients were in the Argentina and in the Germany. The overall survival it was also interesting and more trustable that we have about 90% of the patient survive 2 years or more while they are in the palbociclib and the aromatase inhibitor, and we don't reach the patient who are who are similar patient. About 90% also of the patient were surviving 1 year or more when they receiving the palbociclib or fulvestrant. In Argentina, the data are 90% of the patient were in the 90% of the patient were in the were surviving 18 months or more, and about 98% of the patient were surviving 6 months or more when they receiving the palbociclib and fulvestrant. So this is give you trust that this in the real world, when you actually practicing in the daily life, it is not different. I can say it is even better than what we get in the approved clinical trials. Fintron Trial, it is a comparative data analysis. It was designed as a retrospective analysis of electronic health record from the Fintron Health Longitudinal Database, which is a US community physician database. The patient were hormone receptor positive, HER2 negative metastatic breast cancer, initiated on palbociclib plus letrozole or letrozole alone as first-line therapy. And the real-world progression-free survival were months from the start of palbociclib plus letrozole to the death or disease progression based on clinical assessment. The statistical methods was 1-to-1 propensity score matching used to balance the patient characteristic. Look at the curve, the real-world difference. The palbociclib plus letrozole compared with letrozole alone, you can see a median progression-free survival of 14.5 months compared with 17.1 months, with a hazard ratio of 0.68, and a significant difference in the p-value. The patient who are progression-free at 24 months with 50% in the palbociclib plus letrozole compared to less than 40% in the patient who are in the letrozole alone. This gives you a trust with a median follow-up of 16.8 months. Look at the survival from the Fintron trial. It is not reached in the patient received the palbociclib compared to his patient in the letrozole alone. Yes, Polaris trial, which is palbociclib, hormone receptor advanced breast cancer, a multi-center prospective non-interventional study. Polaris trial. It is basically included patient with hormone receptor positive HER2 negative advanced breast cancer receiving palbociclib plus endocrine therapy, and in the United States or Canada, including both community and academic center. As I mentioned, it is important to include this community practice centers, as they not only reflecting the general population of the patient, but the actual casualty physician who are practicing oncology among community center. They will receive a standard of care data collection. It has also quality of life questionnaire and blood sample collection. The key research point were the treatment pattern, the metastatic treatment breast cancer sequence, the clinical outcome, progression-free survival, overall response rate, and quality of life according to the EORTC and the geriatric assessment. I don't know محسن معانا ولا يومنا خميس، الاثنين عندهم experience بالgeriatric assessment. Scoring activities of daily life and biochemical assessment. At a prospective enrollment, approximately about 2 years, and a follow-up of another 3 years, and the interim and final reports. Look at what we have from this Polaris trial. It is the median age about 64 patients. It includes about 400 patients complete 6 months of treatment at 92 sites of the United States. And this is very important. And the data was collected up to March 2019. It represents a good number, a good population of the patient receive either palbociclib plus aromatase inhibitor as first line, as second line, and palbociclib and fulvestrant as first line, or palbociclib and fulvestrant as second line, or palbociclib, and this represent what we have in the actual life. About 40% of the patient receive palbociclib and aromatase as first line, and around 27% of the patient are receive palbociclib as first line, and 12% of the patient around receive palbociclib and aromatase inhibitor as second line. The menopausal status, around 76% of the patient were postmenopausal, and 14% of the patient were premenopausal. The disease sites, about 72% were non-visceral, and 23, about 1/4 of the patient were visceral disease. And this is very important, as this encourages you to use endocrine therapy who have visceral disease, but not visceral crisis. Remember that the curve I showed you early, that the separation of the curve doesn't happen very early with the start of treatment. It takes time to expect the response from the endocrine therapy. The Acod performance status, most of the patients were performance status 1, and performance status 0 were 43%. But also we have performance status 2 and 3. And the bone metastasis, around more 57% of the patients have bone mets, and 43% were have bone met only. Look at the starting dose. It was most of the patients receive the standard dose, which is 125 milligram per day. And the dose interruption was only less than 30%, while remember in the 2/3 of the patient in the actual Paloma 2 trial need dose interruption. And the dose reduction, about 33% need dose reduction, which is less than what happened in the Paloma 2. The Polaris adverse event were reported, and adverse event according the Polaris trial as first line were 34% compared with 80% of the patient were in the Paloma 2 as neutropenia, and leukopenia 4% compared with 39%, anemia 19% compared with 24%, fatigue 25% compared with 34%. So it is overall far less than we notice in the clinical trial. This gives you more trust and more satisfaction that you are using this medication in the real world. Especially this is electronic, just electronic analysis, and it is evaluation of the. Look at what we have adverse effect within the first months of the using of the palbociclib. You can notice neutropenia, leukopenia, anemia, and with after 3 months you can notice side effect, but still most of them are grade 2 or 1, and those with grade 3 are not that much. Within 6 months of bulbococcolab, the neutropenia was the majority of the patients. The baseline, yes, what is, as I mentioned, when we talk about what's the difference between the real world and the clinical trial, that we don't much include geriatric patient, but here we have geriatric patient. If we notice, أنا كنت حابب يمكن محاسن أو يومنا خميس يعلقوا على الاكسبيرينس بتاعتهم في الجيرياتريك اسسمنت. geriatric assessment, البيزلاين normal were 39%. After 3 months, it is 33%. We have impaired functions in geriatric patients, about more than two-thirds of the patient, and the ADL more than 5 for normal, and 80% in the after 6 months. So the patient who are 70 years observed in the bulbococcolab with endocrine therapy more than 2 months, they were assessed monthly for 3 months, then every 3 months. The physician completed geriatric 8 scores to assess the fertility and functional status. Patient completed activities of daily living tool. This is a score that I wish our colleague will comment on. الحقيقة ربنا يكرمه دكتور صلاح كان من أول الناس المهتمين بالسيس بوينت. Yes, bulbococcolab expanded the last study. It is opened in September 2014. It has a long-term follow-up design, 3 distinct observational periods before enrollment in the study, and the treatment period, bulbococcolab plus letrozole, and the period of assessment, expanded access program, before the expanded access program and the expanded access program. It is provided access to bulbococcolab in advance of commercial availability. دي الissue بتاع الكوست. فلما بقى الكوست available لكل الناس وبقت الانشورنس كومباني او الميديكير او الميديكيد يكفرت، فده غير الشكل في اليونايتد ستيتس. It is a retrospective medical record review. It has a long-term data of 126 patients. 75% had received 2 prior therapies for metastatic breast cancer، وده هيخلينا نتوقع ان الداتا مش هتكون as impressive as expected. It has 15 months. It has 15 months median follow-up from enrollment. ده real world progression free survival, number of period lines. Most of the patients received 3 period three period lines, and the proportion of the this is the either no period chemotherapy line, just one period chemotherapy line, and more than 2 period lines. And this is the distribution of the patient. And of course, as you can expect, this patient have been over-treated, and you can expect their survival and overall survival will affected with previous exposure to many treatment line. This is the proportion of the patient who were surviving after palbociclib plus hormonal therapy. If they receive no barrier line, they have you have 71% of the patient at 12 months. If they have one barrier line, you can have 83% of the patient at 12 months, and patients who were heavily pre-treated, the overall survival around 62% at 12 months. Still, you can find a good survival expectation in patients who have received no barrier chemo treatment compared with patients who received more than 2 barrier lines. So this gives you real trust when the patient have free access or expanded access to this treatment. The sequence of Cdk46 inhibitor across lines of treatment, the real world experience showed that showed the effectiveness in hormone receptor positive HER2 negative patient treated with palbociclib after period treatment with everolimus. Even the objective outcome, we compare the objective outcomes, the complete response, the partial response, stable and progressive disease, that the real world study showed that 78% of the patient had progression. Only 17% of the patient who have been in the clinical trial Paloma or 3 have progression. The clinical benefit was noticed in more than 2/3 of the patients who received this palbociclib, and the median progression-free survival was quite different, 9.7 months compared with 2.9 months. So this is really impressive, and to have a difference between the efficacy with this drug. So in conclusion, this real-world data added to the body of evidence of therapeutic agent, the expanded use into patient group not typically represented in clinical trial. Usual, as I mentioned, the elderly patient, the poor performance status patient. Palbociclib has a large and broadly representative evidence based with multiple real-world studies ongoing around the world. The real-world effectiveness outcome with palbociclib complement what has been demonstrated in the clinical trials. It is even exceed that what we notice in the clinical trials. Dosing and the frequency of dose adjustment of palbociclib in real-world studies are as expected based on clinical trial experience. The real-world studies of palbociclib and other Cdk46 inhibitor are the beginning to elucidate sequence pattern of clinical practice. I think about this, I conclude this presentation, and I would like to thank you being patient with me for all this long time. Thank you.
Thank you very much, Professor Abdeslam, for this very elegant and comprehensive presentation. Actually, you covered the matter very well. And I will start with one question that is addressed from Professor Abbas Omar. Dr. Abbas is asking you why real-world data showed different toxicity profiles compared with the randomized trial data. Do you have an explanation? اتفضل حضرتك.
طبعا انت حضرتك يمكن انا ذكرت نقطتين مهمين. النقطه الاولانيه ان البرفورمانس ستاتس اللي بتكون في الكلينيكال اكسبيرينس في كلينيكال ترايلز بتكون يا اما يا زيرو يا يا 1 بكتير، انما في الريل وورلد احنا بناخد البرفورمانس ستاتس 2 اند مور. الالدرلي بيشن، ودي لازم نتوقعها الحقيقه. يمكن في داتا كتير بتكريتيسايز الكلينيكال ترايلز انها بتحط كات اوف ليميتيشن على البارتيسيبيشن في الكلينيكال ترايلز، ان ما ياخدش عيان عنده 70 سنه. طب ما حضرتك بيجي لك في العياده 80 سنه و90 سنه، هتعملها ايه؟ ما انت ما عندكش داتا بتسبورت. لو انت حضرتك حاططها اي تريتمنت ما عندكش داتا تسبورت، لان مفيش كلينيكال ترايل كان بتسبورت، وده يمكن اهم اكسبلانيشن.
اوكي. مفيش.
هو يمكن دكتور عباس كان في حاجه حابب يسال، ما اعرفش هل الميكروفون ممكن؟
هو بعت السؤال على الكويشن اند انسر. في اي any other questions to Professor عبد السلام يا جماعه؟ any other questions؟ اوكي، يعني مش عارف اشكرك قد ايه يا دكتور عبد السلام، وحضرتك ممكن تقدم الدكتوره يمنى بعد اذنك والتوبيك اللي هتتكلم فيه لو سمحت.
الحقيقه شرفني يمنى من الشباب الصاعد الواعد الحقيقه، يعني مش عارف اقول ايه. يعني هو القسم حظه خلفته بنات كلها، فاحنا عندنا 2 بس شبان دلوقتي نواب، والباقي كلهم بنات. انما الحقيقه يعني بنات رجاله قوي، يعني بنات جدعان جدعان جدعان، وانا فخور بيهم. ويمنى من اكتر الناس النشيطه والملتزمه منضبطه الى حد كبير جدا جدا. وحقيقه انا طلبت من كل النواب ان هم يشير الاكسبيرينس دي، وبشكر فايزر انها سمحت لنا ان احنا نشير في السيمبوزيوم بتاعهم الداتا دي، لانها داتا مهمه جدا جدا. يمنى هتتكلم عنها how we choose and make decision when we are trying to use new medication. البيبر دي اعتقد مهمه، واعتقد ان يمنى هتقدمها بشكل جيد.
Hello, my professors and my colleagues. It's my honor to share with you a short idea about weighing benefits versus harms of new anti-cancer drugs. Hippocrates said, as to disease, make a habit of 2 things, to help or at least to do no harm. It's not a surprise that we are witnessing the explosion of new anti-cancer therapeutic drugs approved by the FDA among the past 3 decades. And these anti-cancer drugs add a more financial burden on both individuals and health systems. When you are discussing with your patient in the clinic, your patient with advanced disease, and you are discussing options for the treatment of their advanced disease and of any new anti-cancer agent. The first question that jump into your mind and your patient mind, is it worth it? To answer this question, it's not easy at all, because to have a good decision, you should have first good information to base this decision on it. Regarding the information, do our patients really know the aim of their treatment and the nature of their disease? Okay, this is an interesting article that has been published in 2012, showing an American study that answered this question, showing around 69% of patients with metastatic lung cancer and around 81% of patients with metastatic colorectal cancer didn't really know that their disease is not, their treatment is not to cure their disease at all. Okay, and this push us to ask ourselves, what is the meaning of the clinical benefits in oncology? The clinical benefit in oncology usually expressed in the terms of survival and quality of life, including cancer-related symptoms. And this should be weighed or traded off against the cost and risks by allowing patients to have a well-balanced information on their disease, on the benefits on their drug, and the cost and risks of this new agent, they can make a good decision with their physician. Clinically important endpoints in clinical trials. The most important endpoints used in clinical trials or definitive endpoints are the overall survival or the survival endpoints and the quality of life. The problem with these endpoints that they usually need longer follow-up for the patients and need larger sample size to have statistically significant results. Other endpoints like disease-free survival, progression-free survival, and overall response rate are commonly used because they need less sample size to have the same clinical significance and with shorter follow-up time. But they can be only of clinical significance if they succeeded to be a surrogate for the quality of life and overall survival, the definitive endpoints. An example for this is in the colorectal cancer, disease-free survival assessed after 3-year median follow-up is a valid surrogate endpoint for 5-year overall survival. A controversial point that was raised by Dr. Abdessalam, and the same question asked by Dr. Abbas, is that patients enrolled into randomized clinical trials usually are very highly selected patients, including restricted eligibility criteria, performance status, and so on. And this usually may not be representative for the real clinical practice, in which we enroll more patients with elderly patients, patients with comorbidities, and patients with worse performance status. So this make an urge to develop a framework to assess the value of anti-cancer drug. And this framework should be using data from individual trials and make a separate scoring system for those drugs for aiming to curative intent versus palliative intent, in giving higher value for the definitive endpoints of overall survival and quality of life rather than the progression-free survival and overall response rate, with another adjustment based on the quality of life and toxicity. This is an interesting article published by Springer in 2013. The authors here wrote or expressed the very good equation to weigh against the cost and benefit of new anti-cancer drug in clinical trials by making the difference between cost of the new drug and the old standard drug. This divided on the effectiveness of the new drug and the difference between new drug and old drug, making the incremental cost effectiveness ratio. This is an individual effort, but more comprehensive scales has been published in 2015. Two very important scales published in 2015. We will discuss them in short today. The first, published by the ISMO, which is the MCPS scale, or the medical oncology magnitude of clinical benefit scale. This scale has two published versions, version 1 and version 1.1. Version 1.2 is to be published this year. This allows us to compare the magnitude of benefit between studies that incorporate different primary outcomes, including the overall survival and other surrogate endpoints like progression-free survival, and making a great emphasis on the quality of life, with studies different designs and focusing also on the toxicity. How that come? Okay, this is the version 1.1 that we will discuss today. You can find it on this link. I will send you the presentation after we finish. As we said, the primary aim is to develop a validated tool to assess the magnitude of clinical benefit, giving the priority to the definitive endpoint, at which the toxicity is less concerned, but the toxicity is, we are concerned more in the toxicity when the primary endpoint is a surrogate endpoint. Okay, as we said, all of these points are included in this scale, but we didn't mention the cost because the cost is omitted from this scale. This scale is European scale with different European countries, different health systems, and different cost of the drugs. So the cost intentionally omitted from this scale. The steps at which this scale is based, first, we will assess the strength of the randomized trial, making or reaching at the end to the grades for the clinical benefits for this drug, and assess the threshold for the hazard ratio of the primary endpoint. Finally, we will adjust this scale according to the presence of severe toxicity or absence of them and the quality of life. Two main domains for this scale, one for the curative, for drugs for curative intent, and one for those for non-curative intent. For curative intent, there is only one form for assessment. For non-curative intent, there are multiple forms in the ESMO website. For the curative intent, when we assess first the strength of evidence of the drug mentioned in the clinical trial, we assess it in terms of benefit grades. And benefit grades in curative intent is expressed in alphabetical order, A, B, and C, in which A and B represent clinically significant beneficial drug, and C is non-clinically beneficially drug. And for the non-curative intent, they are representative in numerical order, starting from 5 to 1, in which the 5 is the most clinically significant beneficial drug, and 4 also is clinically beneficial significant drug, but 1, 2, 3, they are of no clinical benefit drug. To understand this, let's see here some print screens from the forms on the website. This is the first form for the potentially curative drugs. Here, as you see, grade A, B, and C. The assessment is done in two forms. One of them is in the absolute value of the survival, and one in the relative value expressed in the hazard ratio. For example, you find here the drug can be plotted here in the grade A if it has more than 5% improvement of survival more than or equal 3 years follow-up, or improvement in disease-free survival alone if it is the primary endpoint with hazard ratio less than 0.65 without mature survival. And for grade C, less than 3%, and so. You will plot your drug, you will choose according to the data presented in the trials and choose a clinical grade A, B, or C. This is for curative intent. For non-curative intent, another factors will play a role. Non-curative intent, we said there are multiple forms on the website. The first set of forms, when the endpoint is the overall survival. 3 forms are present. The first for less than 1 year, the second 1 to 2 years, and the third for more than 2 years. You are choosing the form according to the drug you are assessing from the clinical design of randomized clinical trial. Other set of forms when the endpoint is a surrogate endpoint, progression-free survival, or time to progression. The third set of form when there's other surrogate endpoints like overall response rate. This is one of them. As you see here, this is for therapeutic agents that are not likely to be curative, but with a primary endpoint of overall survival between 1 to 2 years. We find that this is starting from grade 4 and not from grade 5, because in here, non-curative intent, there's a great emphasis on the quality of life and toxicity. To add the 5th point, for the drug that has the maximum clinical benefit in clinical trial, it will take only grade 3. And this drug will be upgraded or downgraded according to the quality of life and according to the toxicity. Let's assume that the drug already taken the grade 4, and then this drug had a grade 3 or 4 toxicity, or maybe more than this, clinically significant. So this drug will be downgraded to 3, which is now will be clinically non-significant. The next form, also for non-curative intent, but when the endpoint is progression-free survival. And here notice that the starting point is grade 3. We are downgrading now because the quality of life and other factors will take the upper hand. So for maximum clinical benefit from the clinical trial, we'll take the grade 3, which is not enough alone to be clinically of benefit. So we will take. We will assume that the drug already taken grade 3, and we will shift to the next step in the form of the scale, which is the early stopping or crossover of the drug due to survival benefit in the interim analysis. If the drug already has this, we will just mark here and we will jump to the adjustment at the end. Step 3 for the toxicity, a list of toxicities between grade 3 and to grade 5 toxicities. Any one of them you will just mark here and jump to the adjustment. The third one is the quality of life, whether the drug has the quality of life is evaluated as secondary outcome and weighted to the toxicity. And finally, making the adjustment to this. We assumed already that the drug has taken the grade 3, and okay, let's now assume there was an early crossover in the interim due to interim analysis survival benefit. Now the drug will be upgraded to 4 and will be clinically of benefit. If presence of toxicity will be downgraded to 2. And so according to this, it's very, very easy and informative. The last one is when the endpoint of the clinical trial is other than the survival and progression-free survival, namely the response rate and toxicity or quality of life. Look here, when it is only the response rate, the maximum benefit will give you the grade 2 only. Without assessing the toxicity and the quality of life, the drug of no clinical benefit at all. The limitation of this scale, as we said, it didn't include the cause, which is very important on individual level and also on organizational level. The second scale is developed by the Acod, which is the value framework net health benefit worksheet. We will find it also available online. It's much complicated for a little bit, but comprehensive. Also assessing the disease by making a score. The previous score is made on letters or numbers as grades. Here, no, this is a score done on marks. You are making the drug, adding marks for the drug and making final score called net health benefit score. 2 forms are published, one for the adjuvant settings and one for the advanced settings. This is the form for the advanced settings. You are following these steps. Step 1, when you determine the clinical benefit, exactly as we did in the ESMO scale, and the clinical benefit will depend on the primary endpoint. When you use the primary endpoint of overall survival, which is the most definitive, here you are choosing the score 1, 2, 3, 4, or 5 according to the percentage increase in overall survival. But this is not the end. You will multiply by a factor. This factor will be changed according to the primary endpoint. When it is overall survival, this is the largest factor. So let's assume this drug is included here in the category 5. You will multiply by 16, reaching the maximum of NHP score, which is the 80. If it is progression-free survival, the multiplication factor is 11 less, will be less if the response rate is our primary endpoint. This is for step 1. This score will be adjusted according to the toxicity, either to add or subtract from this score according to the presence of grade 3 to 5 toxicity or absence of these toxicity and good tolerability. You will add a maximum 20 to this score, and or subtract maximum 20 from this score in the presence of significant grade 3 to 5 toxicity or intolerability. The third step, another addition or subtraction based on 2 other factors. Remember, in the ESMO, we said the quality of life. Here, it is expressed in the palliation of symptoms of the patient rather than the quality of life. And according to this, we will add to the score 10 points or subtract them. The other one is the another addition of maximum 20 points or subtraction of them according to the improvement in the treatment-free survival. Okay, this is the last point, and we will reach here now the final score at this point. The final score will be put aside with the cost of the drug. Okay, this scale all will be applied to both the drug we are interested in, the new drug, and the standard drug. And you will take the paper of the new drug and you will put it aside with the standard drug, the final score and the cost, the final score and the cost, and you will assess. For the adjuvant settings, it's easier because it's limited here to the clinical benefit as we discussed previously and the toxicity only, and finally you will add the score to the cost. Here, as you said, you have 2 papers of 2 score and 2 cost, and you should evaluate it with according to your experience and concerning your patient's decision. And for decision makers in health systems, they will adjust it according to their opinions. This makes the ASCO scale less informative because we don't have a definitive interpretation for the scale like what in ESMO. We have A and B is clinical benefit, and C is not. 5 and 4 is beneficial drug, and less than that is not, which make it easy for the clinical practice every day. Okay, this is the limitation of the ASCO. As we said, it depends on the decision maker to make their own conclusion. To summarize, this is an example comparing between the 2 frameworks of ASCO and the ESMO. Here, the example is erlotinib versus chemotherapy for EGFR mutated non-small cell lung cancer, and BEVA with chemo versus chemo alone for non-small cell lung cancer. When we apply the steps one by one, the first step is fixed in both, which is the main outcome, the clinical benefit. Will be in the form of a score here in ASCO and in grades in ESMO, grades 1 to 5, because it is non-curative intent. And then the toxicity also included in both. The difference will be in the third part, which is the quality of life in ESMO framework, and will be palliation of symptoms and time to progression. Or treatment-free interval in the ASCO framework. The final result is almost the same. Here we have 44 over 130 for the erlotinib, which is of clinical significance compared to what here in BEVA 16 over 130, it is definitely low score. And for the ESMO, it's grade 4, clinically significant, grade 2 here, non-clinically significant. But this, okay, you are sure in interpretation, here it is just relative to the comparison with the standard. To conclude, as clinicians, we should find the useful framework when assessing and explaining the value of new anti-cancer drug with the patient. And this allows for clearer communication with the patient, especially if we are offering new unfunded and expensive drug with modest benefit. The ISMO framework, as we have seen already, is probably easier to express this value in simple way, and the ASCO is more comprehensive and consider the cost, but it is much complicated. Okay, I will be happy to share with you your thoughts on this point, and thank you.
Okay, Yumna, actually, you far exceeded my expectation. Really, thank you. Excellent presentation, and that's why I asked you to prepare the presentation. It was my expectation that you will do good, but actually you exceed my expectation. And as a matter of fact, I will not say a secret that next exam for either master degree or MD should include questions about this topic. This is not a secret. Finally, I would like to ask our Kenyan colleague to insist on this kind of studies, because we are all poor countries and we have to give the patient something of real benefit before rushing to just a new drug or treatment tool. Thanks again, Yumna, and I would like to appreciate Pfizer that they sponsor this really scientific meeting. It was a real data, not much biased by any or contaminated by any commercial contamination. And I would like to listen from you any questions. And I would like to again thank the attendee, Dr. Abbas Omar, Dr. Ahmed Goueli, Dr. Tony. How are you, Tony? I'm glad to see you here with us. And actually, one of the colleagues that joining us today is a student in 4th year. He just started her round today, Zainab. Okay. Do I expect questions? Because you was very clear, Yumna, and I think people, the message was delivered very good. I don't think there is much questions for you. And I would like to thank all the participants today and again appreciate Pfizer for having the meeting with us. And inshallah, we will see. عندنا وصل سؤال اهو. احمدك يا رب. Tony Ramadan Kareem, thank you, Tony. I would like عايز اقول ايه عيد مبارك عليكم كل الإخوة المسيحيين and enjoy حد السعف بكرة إن شاء الله، وإن شاء الله ربنا يجعل بلدنا آمنة وعامرة دايما يا رب. شكرا يا توني، و appreciate إن أنت you attend with us. بكرة إن شاء الله we will have our board meeting إن شاء الله. Thanks a lot for the attendee, and thanks again Pfizer, and thanks finally again and again Yumna.
Thank you.